It is my pleasure once again to welcome you to the February edition of our monthly clinical meeting for year 2024. This is not just a monthly clinical meeting, but it also doubles as our annual general meeting. And it's a special occasion for us because at the AGM like this, we normally have the privilege of hosting the biennial lecture in memory of our teacher, late Professor Charles Adisa. So that will be happening today. And also, we are going to have a change of baton today with regards to the executives. We have spent 4 years, and in line with our constitution, the executive has to be changed after a particular period of time. So we have a lot of activities lined up for today, but we are going to keep to time as much as possible. And to start with that, I want to bring the indulgence of our international rapporteur, Dr. Iguare. He has been so magnanimous to this association that ever since we started, he has always taken it upon himself to moderate, correct us, give us advice here and there. And here we are today. This is 4 years down the lane. You have never complained that you are tired. We so much appreciate you, sir. And I want to hand over the moderation. Yes, I want to hand over the moderation of this August meeting to you, sir, Dr. Iguare. So we are starting with the scientific meeting. Thereafter, we go to the business meeting of the day. Over to you, sir, Dr. Iguare.
Yeah, good evening, everyone. And
Good evening.
I want to thank you very much for that very kind comment. I think I consider it a rare privilege, to have this fellowship with my brothers, So, I mean, if you ask me to pay to attend these meetings, I will pay. So I don't consider it a burden at all. So I thank you all, and I want to thank everybody for the enthusiasm, the interest that has been shown by everybody since the inception of this association. I can't even believe that it's 4 years already, but and I want to thank God that the enthusiasm has been high, the attendance rate has always been high, and I want to give all that credit also to the association and the executive. They have been fantastic. To bring an association from nothing to where we are now within a space of 4 years, and I think it's a testament to your dedication and your interest in seeing that this succeeds. So I am very grateful to the executive that will be transiting today. And in particular, I also want to thank Dr. Adejumo, who has been an able president over this period of time, and his other able executive members. So Dr. Adejumo had asked me to moderate the session, and I'm sure we all have the program for this evening. So in terms of the program, I want to just say one of the things we are doing today is as part of this association is to give the memorial lecture for Professor Charles Adisa. And we all know him. He was a good friend. In fact, I did my youth service with him in Katsina. So we were both youth corpers in Katsina with his lovely wife, Chizoba. We were all corpers in Katsina together. So when the last time I actually met him was in Jerusalem when we had the Steve Westner's meeting in Jerusalem. But to God be the glory, and he led a very exciting life. He didn't waste 1 minute of his life. So even though he left very early, but he fulfilled purpose. So we can actually take comfort in that. But today, as part of this, there will be a citation of Professor Adisa by the Secretary of the Association. I will just invite the Secretary to give the citation, if we are ready.
Thank you very much. I have been given the honor to speak about the life of Professor Adeyinka Charles Adisa, who passed on the 28th of December 2020. He left behind a legacy of distinction and has shown himself to be a man of distinction, which started from his early life and his early education, where he repeatedly was awarded distinctions in both primary and secondary levels of education. He graduated from the University of Ibadan in 1998 in medicine and surgery with a distinction in anatomy. He completed his postgraduate degree and fellowship training in surgery and defended his work at the West African College of Surgeons at the Part 2 examination in 1995. He excelled again with distinction, bagging the Jide Ajayi Gold Medal in surgery, awarded to the best graduating surgeon at the finals of the West African College of Surgeons examinations. He was great in every aspect of his life. At the completion of his surgical training in 1995, rather than go for chartered pathways of established schools, he went into a newly established medical school, which is the Abia State University Teaching Hospital in Aba. Setting roots in Abia State, he progressed from lecturer 1 to professor of surgery within a remarkable short period of time. His career spanned from the 1995, where he was both a consultant and a lecturer 1. He became a senior lecturer in the year 2000, an associate professor by the year 2004, a professor of surgery from the year 2007 till his death. He was a department head of surgery from 2000 to 2007. He was the pioneering director of postgraduate resident training in his institution, which was from the year 2000 till the time he died. He was the former dean of clinical medicine of the Aba campus, a member of the Court of Examiners in the West African College of Surgeons. He was an editor in the Journal of Global Medicine, editor-in-chief for the Journal of Medical Investigation and Practice. He was the chairman of Outreach Committee of the West African College of Surgeons. He was also a member of the accreditation teams of the West African College of Surgeons. He was a coordinator of the Ptolemy Project. He was a fellow of the West African College, the American College of Surgeons, as well as the International College of Surgeons. He was a collaborator in the International Agency for Research on Cancer, a past president of the Nigerian Christian Graduate Fellowship, and a founding member of this association. He has trained and raised surgeons of great ilk. He believed strongly in mentoring. He was a man of faith and he loved associating with people, a Christian that had strong values in mentorship, connections, and collaboration. And this was evidenced by several social media platforms that he pioneered and was a part of to link people in his circles of influence in every group and community he belonged to. He taught us all the meaning of community, faith, and kindness. He lived a life of purpose. In spite of all his other commitments, he loved and was devoted to his family. We are grateful to his family because they gave us him. He lived a life of impact, and I will end this citation with a quote from Mary Angelou. A great soul serves everybody all the time. A great soul never dies. It brings us together over and over again. Thank you very much.
Thank you, Madam Secretary, and for that very wonderful citation. And I want to thank the association for immortalizing Professor Adisa, because this association was primarily his brainchild. And when we met at Jerusalem, this was where it all started. And thank everybody who are here, who are pioneer members of the association. I also want to thank my very good friend Augustine Ratulam, all the way from Italy, who was also very instrumental to the inception of this organization. So I think that was just a synopsis of the life of Professor Adisa, but I want to tell you that he was, a man of purpose. Every minute of his life meant something. And I hope if there's one thing we learn from him, is to learn that our lives should be purposeful, that every day of our lives, so that, when we are gone, we will be remembered by the good that we have done. Thank you very much, Madam Secretary. Now, we
Sir,
don't.
I don't know whether any of the family representative is on the platform now.
Yeah, let me look. I don't know if they are here, if they want to say something. I know they were invited. I'm just looking at the. No, I can't see anyone here, but if there's somebody, maybe if they join later, we can also recognize them and acknowledge their presence. Yeah. So it's my great pleasure to introduce the memorial lecture, Professor Yinka Charles Adisa memorial lecture. Now, I don't know, is anybody giving a citation on Professor Chirdan? Is there a citation?
No, we didn't make provision for that.
Okay, maybe next time we're going to include that as part of our yeah, so that there has to be a citation for the lecturer of the day. But I'm sure Professor Chirdan will tell us a bit about himself after the lecture before he takes some questions.
Okay, sir. Thank you, sir.
Okay.
Yeah. Dr. Ulasi, can we have the pre-recorded lecture, please?
Good evening, all. I'm highly honored to present the Professor Charles Adeyinka Adisa Memorial Lecture. Several things have been said about Charles Adisa of blessed memory. To me, it is a very great honor because Charles Adisa was my very good friend. We've met a number of times. He visited me anytime he was in Jos, and on several occasions, we had to do some college activities together. So this is a very special moment for me. And as we continue to remember him, I wish him I wish his soul a wonderful rest until we meet to part no more. The topic of this memorial lecture is the management of Hirschsprung disease in Nigerian children. Introducing the topic, Hirschsprung disease is a developmental disorder in which ganglion cells are absent, usually in the distal colon. This results in a functional intestinal obstruction. Failure to pass meconium within the first 24 to 48 hours of birth is suspicious of Hirschsprung disease. And usually the diagnosis is critical and is made through a rectal biopsy. The definitive treatment is removal of the aganglionated bowel and then effecting a coloanal anastomosis. Hirschsprung disease is one of those diseases that has very interesting historical background. Since it was first described in 1691, it was Harold Hirschsprung who popularized the disease in 1886. At that time, a lot was not known about the disease, and until the mid-20th century, that's 1948, that Whitehouse and Cunningham reported aganglionosis of the distal colon. Then, around the same time, working on Whitehouse and Cunningham's findings, Swenson and Bill performed a corrective rectal sigmoidectomy with a coloanal anastomosis in 1948. Other procedures like the Duhamel's procedure, the Suave procedure followed. But until 1998, that the transanal single-stage procedure was introduced. Many surgeons still perform, the transanal endorectal surgery, and also a number of them, and quite a number of them, perform the transanal Swenson's procedure. Recently, the laparoscopic assisted transanal procedures have been added. As the embryology, ganglion cells usually migrate from the neural crests where they forgot to colonize the entire enteric nervous system within the first 18 weeks of gestation. The protein tyrosine kinase receptor, being a product of RET gene, is involved in this migration. And in Hirschsprung disease fetuses, this migration is disturbed, leading to absence of these ganglion cells in the distal bowel. But another theory states that these ganglion cells actually reach their destination, and because of the hostile environment, they die off or do not function properly, thus leading to intestinal obstruction due to uncoordinated or poor peristalsis in the affected segment. So what's the epidemiology? It is a relatively common disease, the worldwide incidence ranging from 1 in 5,000 to 1 in 7,000 live births. Most serious, 1 in 5,000 live births. The disease affects all races, though it is 3 times more common in people of Asian descent. The male to female ratio is 4:1 in the rectosigmoid disease. But for the long segment disease, it's been reported that Hirschsprung disease is one of those diseases that has very interesting historical background. The long segment disease has been reported that it may even be 1:1 or in some cases 2:1. Most patients are neonates, but in our own practice, that's about 39%. That's between 20 to 40% of our patients are neonates. So most of our patients present after the neonatal period. The incidence in Nigeria, like most other diseases, is not known. But most of the major teaching hospitals in Nigeria see between 10 to 15 new cases per year. Recently, I was looking at our own patients, and I discovered that we see between 10 to 12 patients every year at the Jos University Teaching Hospital. The disease is associated with chromosomal anomalies or some other syndrome in about 9% of cases. And these chromosomal anomalies include things like Down syndrome, neurocrystopathies, and many others. Then the genetics of the disease is complex and is a multifactorial, it's multifactorial with low genetic penetrance. The RET gene is mainly implicated in patients with Hirschsprung disease. So abnormalities, so some abnormalities in the RET gene, as I told you earlier, the protein tyrosine kinase, which is regulated by the Rett gene, is responsible for the migration of these neural crest cells in the in the fetus, and is defective in patients with Hirschsprung disease, in fetuses with Hirschsprung disease. So definitely the Rett gene plays a very important role in the pathogenesis of Hirschsprung disease. What is the pathology? The gross pathology is as depicted in this picture. There's a proximal dilated segment with a funnel-shaped transition zone and a distal constriction or constricted bowel, which is mainly the rectum and the lower part of the sigmoid colon. Now, there's histologically, there's absence of ganglion cells in the distal column, which is actually the hallmark of the disease. The ganglion cells are absent in both the submucous and the mesenteric plexuses. And then the nerves, the nerve trunks are usually very large, thickened, non-myelinated nerve trunks, which are found in the aganglionic segment of the bowel. So what is the pathophysiology? Now, ganglion cells are mandatory for bowel peristalsis and relaxation. Other abnormalities which have been found in patients with Hirschsprung disease is a hypertrophy of the extrinsic nerve fibers in the submucosa, and then reduced interstitial cells of Cajal. The interstitial cells of Cajal are actually the pacemaker cells. There's abnormality of these cells, and they are also reduced in number. Now, the aganglionosis with associated abnormalities lead to constant constriction and loss of peristalsis in the affected bowel. This then leads to bowel obstruction at the affected segment. And then there's therefore a proximal ganglionated bowel, giving rise to that, the proximal ganglionated bowel becomes dilated, giving rise to what we call megacolon. In fact, the disease was, some other name for it is congenital megacolon. But actually, it's interesting to note that the big colon is actually not the problem, but that small constricted segment that has the pathology. Now, the morphologic classification is based on the length of the bowel that is involved. Most of the patients have the rectosigmoid disease, which is usually referred to as a short segment disease. Then the rectum is involved in about 1% of patients. If the large bowel proximal to the sigmoid colon is involved, it is called the long segment disease, and that occurs in 10% of patients. Then total colonic aganglionosis occurs in 4%, and total intestinal aganglionosis, which is actually not compatible with life, occurs in 0.4%. Recently, there had been a lot of research to do some surgery for patients with total intestinal aganglionosis, but it's actually that is beyond the scope of this lecture. Now, the clinical presentation. The clinical presentation can actually be divided into 3 distinct phases, or let me say there are 3 modes of presentation. I have the newborn who is born with bowel obstruction, and then there's the constipation in the infant or the older child, including adult cases, and then the Hirschsprung's associated enterocolitis. Now, for newborn with bowel obstruction, they constitute less than 40% of our own patients, but in high-income countries, they are actually, most of the patients present during the neonatal period. So it's a neonatal disease for them. More than 90% of patients present during the neonatal period. They usually have that history of delayed passage of meconium. Then there's progressive abdominal distension, bilious or sometimes feculent vomiting, especially in late cases with bowel obstruction. And then they also have poor feeding. Then the older child with constipation would usually present with chronic constipation starting from birth, then failure to thrive with poor feeding, and sometimes gross abdominal distension as depicted in these pictures showing there. And then sometimes they may have sigmoid volvulus. Sigmoid volvulus had been described. These patients usually have dilated sigmoid colon with fecal impaction. And because of that fecal load, the colon is prone to twisting, and they tend to have sigmoid volvulus. Then the third mode of presentation is Hirschsprung's associated enterocolitis, which is a serious complication of Hirschsprung disease that is associated with high morbidity and mortality. Unfortunately, some patients actually present, their first presentation is with the Hirschsprung's associated enterocolitis. The other thing about that is that even patients that have had surgery may present with post-operative Hirschsprung's associated enterocolitis. The pathogenesis of this complication is not well understood, but is usually a complex interplay between a dysfunctional enteric nervous system and abnormal mucin production, insufficient immunoglobulin secretion, and then an unbalanced intestinal flora. All those are thought to play a major role in the pathogenesis of Hirschsprung's associated enterocolitis. So what are the investigations that we usually do? In Nigeria and in Jos in particular, we have a number of investigations that we do: plain abdominal X-ray, contrast enema, rectal biopsy, and then sometimes exploratory laparotomy. A number of other investigations like the anorectal manometry, usually not available to us and most other centers in Nigeria. And then recently, we've been having a lot of laboratories that do immunohistochemical techniques. And even though we've not started asking our patients to do that, this is an important tool for making a diagnosis. But the diagnosis is actually hinged on a rectal biopsy. Now, treatment of this disease. The initial management will include resuscitation and colonic decompression. Now, the resuscitation and treatment of complications will include rehydration and correction of the electrolyte derangements, nasogastric decompression in patients with gross abdominal distension and vomiting, especially those who are presenting late with this complication. Then intravenous broad-spectrum antibiotics to prevent progression of septicemia is important to stabilize them before surgery. And then a number of them may have nutritional deficiencies. So nutritional rehabilitation, some of them through nasogastric feeding or even parenteral nutrition, especially in patients with total colonic aganglionosis, may be needed. Now, a colonic decompression is necessary once the diagnosis is made. And this can be done by colonic lavage, a frequent lavage or rectal washout on a regular basis, or in some cases, where quite few of them may end up having to do colostomy. A leveling colostomy, which is done just above the transition zone, is indicated in very sick babies, grossly dilated, redundant, and flabby colon, in patients with Hirschsprung's associated enterocolitis, and if they have impacted fibuloma, and sometimes uncooperative parents, because we need these parents to do continuous rectal washout even at home for colonic decompression. Now, what's the surgical management? Now, the surgical management involves resection of the aganglionic segment. That's the segment that's aganglionic, and effecting a coloanal anastomosis. Traditionally, this was achieved in 3 stages. Okay. Now, a colostomy formation, then the definitive procedure is done, and then later a colostomy is closed. And then the 2-stage procedure include a transition zone colostomy, followed by the colostomy takedown at the definitive pull-through. But most of patients that we do in Nigeria and most other centers all over the world, they prefer doing a single-stage primary pull-through. This can be done through a Suave procedure or the Swenson's procedure. And now there are 3 very major procedures, or very popular procedures that are done: Swenson, Duhamel, Suave. Now the Duhamel is mainly done transabdominally, but the Swenson and then the Suave procedure can be done transanally. Yeah. It's been discovered that most results of one-stage procedure are comparable to the multi-stage procedure. Now, so I'll briefly describe the transanal pull-through. Now, in Jos, we started doing the transanal pull-through as far back as 2006. Most of the patients, the initial periods, were doing the transanal endorectal pull-through or the transanal Suave. But since 2017 or 18 thereabout, we started doing the transanal Swenson's procedure. Even though we still do the transanal Suave, but we do both cases. And in many parts of the country, many parts of the country, either the Suave or the Swenson can be done transanally. Now, patient selection is very, very important to avoid unnecessary morbidity and mortality. It's usually the transanal pull-through is appropriate for the rectosigmoid disease, and infants are more suitable, usually very safe in neonates. Initially, I used to take my patients at 3 years, but nowadays we can do children who are even up to 5 years. I've done a 10-year-old transanally. But once the patient is, the child is more than 5 years, it's you have to be careful in doing a transanal pull-through. And if the colon is very large, it is actually safer to do a stage operation. You can actually resect the sigmoid colon and then bring out stoma, and then you can do a pull-through at the second stage. Now, pre-operative preparation will include histologic diagnosis. Have to confirm the diagnosis because it's not a simple procedure. The barium enema is important in knowing the site, and then you also have to define the transition zone. Barium enema will help you, and correct any nutritional deficiencies and fluid abnormalities. The anemia is corrected. It has to be corrected because most of these patients will lose blood, and it's not good to operate on a patient whose PCV is less than 30. Now, patients with long segment disease and total colon aganglionosis are not usually suitable for transanal pull-through. Infants are more suitable, and okay, this is it. Okay. Now, so the patient is usually in a lithotomy position, and the urinary catheter is put in place. Now the abdomen is prepped, and this is important because there may be an umbilical incision to inspect and do and look at the transition zone, possibly even do a frozen section at that time. And then the operation site is prepared using povidone iodine. And then the anal canal is exposed with stay sutures. Usually I use stay sutures because I don't have the Lone Star self-returning refractor. But if you have that, it is a very wonderful tool. It saves a lot of time. And then the normal saline is used to dilute adrenaline. Have 1 in 200,000 dilution, which is injected submucosally above about 2 centimeters above the dentate line. And then this usually facilitates the mucosal dissection for the transanal and the rectal pull-through. For the transanal Swenson, I would usually, apart from the submucosal injection, I try to inject it deeply. And then, of course, when you're doing that, you need to alert the anesthetist because the adrenaline is easily absorbed and it can cause some problems with the heart. And the section usually starts about 2 centimeters above the dentate line. It is progressed, and then on reaching the peritoneal reflection, that's at least 4 centimeters of the mucosectomy, the muzzle of the rectum is incised circumferentially to expose the whole rectum. For the Swenson's procedure, the initial incision is actually full thickness. So the rectum is excised, starting right from the beginning, full thickness. The section is made. Then the sigmoid vessels are cauterized and all ligated. The sigmoid colon is then dissected until the transition zone is reached. At this stage, I would do a frozen section, and in most situations, frozen sections may not be available in Nigeria. So we will just note that and try to do the dissection at least 5 centimeters or more above the macroscopic transition zone. Then for patients who are doing a Suave procedure, once the cuff is more than 4 centimeters, it is advised that the posterior seromyotomy is done before the coloanal anastomosis. And the resection and anastomosis usually starts anteriorly, and it continues up to the posterior aspect. After removing the sutures, the patient will look like this. After removing the stay sutures, this is the final result. Now, the catheter is usually removed between 12 to 24 hours. Then oral feeding starts 24 to 48 hours, and the patient is discharged shortly after, in 2 to 5 days. And then I usually see them in the clinic 2 weekly for 6 weeks, and then monthly for 3 months, and then 3 monthly for at least a year. Most of our patients are lost to follow-up. In the first visit, I do a rectal examination, and I looked out for early postoperative complications. Usually a routine postoperative dilatation is not performed, except for very long cases where there's stricture, then you may need to do dilatation. Now, the postoperative complications are as seen in the table: early complications, anastomotic leak and cough abscesses, bowel obstruction, perineal excoriations, wound infection, wound dehiscence. Now, bowel obstruction for the leg cases, and then constipation and post-operative Hirschsprung-associated enterocolitis can occur, and then stricture, especially after the Swenson's procedure. And a number of hospitals in Nigeria, the laparoscopic assisted transanal pull-through has been introduced, and a number of colleagues are doing that. However, in my center in Jos, usually we do not do the laparoscopic assisted. Just a word about total colonic aganglionosis and roundup. The total colonic aganglionosis accounts for about 4% of children with Hirschsprung disease. It's a very challenging subset with increased morbidity and mortality. Usually difficult to diagnose. Sometimes we need to do a laparotomy in order to diagnose this, make a diagnosis. And in a number of them, in terminal ileum transition zone, of course, it's 75%, mid-ileum is 20%, and the jejunum 5%. Now, patients may require long-term parenteral nutrition or long-term nutritional rehabilitation. Now, an ileostomy is usually done, and the definitive surgery is done later. As like I said earlier, it is not advisable to do the one-stage transanal pull-through in patients with total colonic aganglionosis. Procedures like the Martin's modification of the Duhamel's procedure, the Kimura's colonic patch, and then the standard endorectal pull-through, or even sometimes the J-pouch reconstruction can be done in patients with total colonic aganglionosis. The prognosis is usually variable, but surgery seems to be a very good way of getting satisfactory results. Almost 90% of the patients have very satisfactory results. Other patients have persistent constipation or even incontinence after surgery. Bowel functions may normalize after initial problems for years. Patients with TCA have poorer outcome. Then patients with associated chromosomal anomalies and other syndromes tend to have poorer prognosis. Now, what is the future directions in the management of patients with Hirschsprung disease? These are still very experimental. We're not doing the experiment even in Nigeria, but in advanced economies, the regenerative strategies are done, and we're hoping that this may help to improve the lives of patients with Hirschsprung's disease, and that may obviate the need for surgical resection. So, in conclusion, Hirschsprung disease. In Hirschsprung disease, ganglion cells in the distal bowel are absent, leading to functional bowel obstruction. Delayed passage of meconium should lead to assessment of a child for Hirschsprung disease. Definitive diagnosis is usually done by a rectal biopsy. Most patients are treated by surgical excision of the aganglionic bowel with a coloanal anastomosis. And the transanal single-stage procedures are prepared. Most patients have satisfactory outcome after surgical treatment. And we're hoping that regenerative strategies, when introduced, may be very useful in the future management of patients with Hirschsprung disease. Thank you for listening. And once more, I'm very grateful for your invitation to give this very, very interesting lecture, memorial lecture, in memory of my very good friend, Professor Adisa. May his soul continue to rest in peace.
Amen.
Thank you so much. This is an excellent, excellent lecture, very stylish and very comprehensive. I think we can all get our full CMA points here today because we've gone through school about Hirschsprung's disease. Thank you so much once again. Please, if we have questions, can we stop the sharing so that we can have everybody on board? Yeah, thank you. So Professor Chirdan is still with us. So if we have questions, you may signify by just raising your hand, and let me see if there are questions. Yeah, there are a lot of congratulations, and people are thanking Professor Chirdan for the wonderful, interesting lecture. But please, if you have questions, can you indicate? Okay, while we're waiting for the questions, I just wanted to ask Professor Chirdan. I know you mentioned immunohistochemistry as one of the new innovative way of testing these patients. We know that the aganglionosis in the rectosigmoid, you talked about the pacemaker cells. I don't know the myenteric nerve plexus of Messner and the Iobax submucosal plexus. Are they of any significance in the contributing to aganglionosis?
Yeah, thank you. Yes, the like I said earlier, of course, the ganglion cells as they come in, they those now in between the muscles, that's the over plexuses, and then the Meissner's plexus, submucosal plexuses. Now, those ones are very important for normal bowel function. Okay, peristalsis, bowel movements, and other things, including even the blood regulation of blood, circulation. So they are very, very important, and those are the ones that are absent, okay, in patients with Hirschsprung's disease. And when they are absent, of course, I didn't describe the full pathophysiology, but the thing is that they coordinate all these functions. And once they are absent, there's a functional intestinal obstruction. And of course, the aim is to remove that segment and bring down the ganglionated segment and anastomosis to the anal canal. Of course, the immunohistochemistry will help in making those. In fact, those that you send for immunohistochemistry are the ones that you're not too sure, even after, maybe routine H&E. Sometimes you may even need to do acetylcholinesterase staining to be able to make the diagnosis. Thank you.
Great. Thank you so much. That's very helpful. Yeah, the other question I wanted to ask is, in terms of the conservative management of the megacolon, in terms of decompression, do you use repeated colonoscopy for decompressing these patients? I know you talked about the rectal lavage. Can you decompress these patients? I'm just wondering, because I haven't done one of these. The aganglionotic segment, is this in spasm that it wouldn't allow a colonoscope? True or?
No. Colonoscopy, maybe you're not too sure diagnosis. As I said again, the number of differential diagnosis, even though I didn't give that, patients with delayed passage of meconium or with chronic constipation. However, for patients that you're almost certain, the simple thing is to decompress. Most of the times, you may just need a tube, pass it in, and then you do those rectal washout, just to reduce the fecal load and other things, so that you'll be able to do the aganglionosis, to do the definitive surgery. Of course, sigmoidoscopy or colonoscopy, maybe for adults, we do not have too many adults. Yes, I've had a number of my adult colleagues who've called me for chronic constipation. They've done some, somebody was actually diagnosed with a tumor. They did this thing. And then when they went to do a colostomy, they discovered that, wow, this is classic. Distal constriction with a proximal dilated bowel. And they called me, but we ended up with a colostomy. Then I later had to do that one, an abdominal Swenson's procedure for the adult. Maybe for those ones with chronic constipation, you may end up having to do a colonoscopy just for the diagnosis. But for those, especially children, like I said earlier, once you have that delayed passage of meconium and then repeated constipation, it's good to do a rectal biopsy. And once you're able to get the diagnosis through routine H&E and a number of other staining, you'll be able to conclude probably this is Hirschsprung's disease, and you go ahead and do a pull-through. Thank you.
Great. Thank you very much.
I think that's a room for laparoscopic. Yes, okay, go ahead.
Oh, you were
Somebody
not
was asking of laparoscopic pull-through. Yes, like I said, quite a number, in fact, a number of centers. There's one Dr. Arwa Igwe in Lagos, a young man who is doing a lot of laparoscopic pull-through, maybe lap-assisted pull-through, even here in Nigeria. And of course, abroad, quite a number of them will do lap-assisted. I've done a few, one or two, but it's not something that we do routinely in Nigeria. Yes, you were trying to say something. Sorry for...
No, that's great. Thanks very much. I was just saying that there are two questions on the platform, and I know Dr. Adigije is still has indicated. I'll just ask these two questions, and then I'll go to Dr. Adigije. It says, what are your suture options and stapler options if you are to use both in open and laparoscopic? In fact, that was one of my questions I wanted to ask. I don't know what your view about restorative stapled coloidal anastomosis versus just the pull-through and hand-sewn anastomosis. But the question there, it says, what are your options?
Yes, thank you for the question. For staplers, you know, the problem of staplers in Nigeria, expensive, this and that. However, you can use that, but most people who use staplers will use it for patients that you're doing the Duhamel's procedure. Okay, the other anal anastomosis, you can easily use our own sutures, but definitely what I use is Vicryl. Most of the times, I've one or two occasions I had to use a PDS, but I think a bit PDS is a bit stiff, and post-operatively they tend to have a lot of irritation around the anus. So I prefer using Vicryl, depending on the age of the, if it is a neonate, of course. By the way, it's quite easily done in neonates. I discovered that it's easier to actually do the surgery in neonates and young infants than even in older people. So those ones you can, depending on maybe a 2 or 3 or suture Vicryl, you can use that.
Yeah, I agree with you. In coloidal anastomosis, hand-sewn, I think Vicryl would be. I think the half-life of Vicryl is long enough to allow primary healing. So
yes,
and just the monofilamentous ones, they create more irritation. I agree with you.
Yeah.
And there's another question there from Dr. Yewale and Sabiru Yewale. It says, in patients with enterocolitis, is it possible to use a stent for the initial decompression?
Well, yeah, stent probably I do not use stent. I try as much as possible to do a repeated decompression. However, if I am not achieving decompression and the enteropolitis is not going, it's better I give a stoma, and then I do it as a stage procedure. So that's what I do.
Okay. Thank you. There's one more question there, but I'll go to Dr. Adirije. Dr. Adirije, if you can unmute yourself.
Good evening, all.
Good evening.
Good evening.
Thank you, Prof, for this masterclass presentation. I've always been one of my mentors. I'll keep on learning from you. In honor of one of my teachers, also Prof. Adisa, who was also one of my teachers or lecturers in those days. Thank you, sir. So I have a case in hand, a 23-year-old female who presented like 2 months ago with history of chronic constipation that dates back to childhood. So we made clinical diagnosis of Hirschsprung disease. She had a rectal biopsy, which was in keeping with Hirschsprung disease. So I invited the pediatric surgeons, so I'm communicating with them, but they requested for immunohistochemistry, and the immunohistochemistry came out to be hypoganglionosis.
Yeah.
So the pediatric surgeon now counseled the patient that the prognosis with hypoganglionosis is somehow different from Hirschsprung disease. And we are in between, should we go in for surgery or what are we going to do? So I said, this is an opportunity for me to seek for your advice. In this situation, our major concern is constipation. She's married, probably will be getting pregnant very soon. So I said, let me discuss this case with you. Thank you, Prof.
Yeah, thank you very much. I think I've seen a number of 1 or 2 patients like that. The adults, it depends on the length of the constricted segment. If it's just a little, maybe something like just the rectum, I would rather go and do something like a lymph myectomy, all right? And in doing that, I specifically try to pick some part of the sphincter, so that I do that. You can, it relaxes the sphincter. However, in places people who have buttocks, yes, you can actually inject that, and you may end up having a good outcome. So again, you need to define if the length is quite long, you may just end up having to do a pull-through. But if it is a short segment disease or ultra short segment, if it's an ultra short segment disease, I don't know if anybody has buttocks in Nigeria, but I have never used it. I probably saw it when I was out of the country, a few in Israel and a few places here and there where. But we try to use that, especially if the patient that's after surgery, can actually inject that. But for this patient in particular, probably I may need to get more information before I advise Dr. Adigije. Yes. Yeah.
Thank you, Prof. Thank you, sir.
Thank you.
Thank you very much. And there's another question here from Dr. George Ngok. It says, thank you, sir, for the lecture. Please, I will want you to make a comment on leveling colon biopsies in non-availability of frozen sections in the African context.
Yes, thank you very much. Yeah, a leveling colostomy is just a colostomy or a leveling biopsy, just a biopsy above the transition. But when you go in to do the biopsy, it's better to take at least 3, take it at 3 sites, 1 at the transition zone, 1 below the transition zone, and 1 above the transition zone. Now, frozen section, yes, we have a lot of problems with frozen section, but recently, even this year, probably last week, I did a patient transanal pull-through, And my pathology department, they were able to give me a frozen section. So it's possible, even wherever we are in Nigeria, we can actually arrange. But once you're able to tell the pathologist on time, they can arrange for a frozen section for you. The only problem I get with the frozen section is that it delays my surgery a bit, but 20 minutes is worth waiting, maybe 10, 15, 20 minutes, because it's very, it's not a small surgery. It's better to get a good histology other than going to do a surgery that may affect the life of the patient for the rest of the patient's life. I don't know whether I've addressed that. Thank you. But I just saw somebody who made a comment that in their center they use Botox. So that's very good. If you have Botox, for those patients that maybe some hypoganglionosis, but the level again is important. You may just use Botox. Post-operatively, you can use Botox. Thank you.
Great, thank you very much. And we have a question from Dr. Salu, or a comment from Dr. Salu. Says, thank you, Professor Chirdan, for a great lecture. I think there's a room for laparoscopic pull-through without any open assistance in many centers around the world.
Yes, I agree with you, Salu, my very good friend. And thank you. You've been doing a lot of laparoscopic surgery in Abuja and everything. So why not? You can do that. But in many other centers too. In fact, I've been reviewing some of them, and discovered that even the laparoscopic pull-through, they discover that the lap-assisted tend to have more complications than the simple primary transanal pull-through. So it depends on your experience with laparoscopy. Thank you.
And Dr. Adigije, I saw your hand again. Did you have another question or comment?
No, Prof. No, Prof. That was the initial one.
Okay, great. All right, thank you. And Professor Adeye, you perforation more likely if a stent is deployed in the stenting of enterocolitis. Recession and stoma is better.
Yes, I agree with you very well. I mean, especially those children with enterocolitis tend to have very flappy colon, and any small thing, anything rigid there will just perforate them. And most of the mortality in the literature are those that have perforation. So it's very, very, very important that you don't just stand. Even the using the tubes which you use to do decompression, you have to be very careful because they can cause perforation and you lose those patients. So the mortality is quite high in them. Thank you for the comment.
Thank you. And there are two questions from Dr. Ajogu Stevenson. It says, I have two questions. Number one, taking the biopsy, where do you take the sample? This is because there could be a long segment and a short segment. How do you know the length of the segment involved? By taking a biopsy at a point, maybe a biopsy at the sigmoid. And question number two, I didn't understand how you explained the resection and anastomosis using a one-stage transanal pull-through. Do you completely resect the segment involved?
Yes, thank you. For the biopsies, for children, especially our own patients, by the time they present, the transition zone is very obvious. The only problem is if they're presenting during the neonatal period, where the transition zone may be too obvious, may not be too obvious, and therefore that may confuse you. And then for patients with total colonic ganglionosis, TCA, you tend to, the whole bowel is almost uniform. I mean, the large bowel. So in those cases, if you do a laparotomy, it's good to take an appendix biopsy. And once that's ganglion cells in the appendix, most likely you're not dealing with total colonic ganglionosis. If there are no ganglion cells in the appendix, of course, there are some problems here and there, but if there are no ganglion cells in the appendix, most likely you're dealing with total colonic aganglionosis. And as I showed you in the slide, there are some number of them, 75% of them, you have transition zone in the ileum, while others may be high up there. So it's good when you are doing the biopsy, you have to do the biopsy. That's for the frozen section. They do biopsy at least 2 or 3, one above the transition zone, one at the transition zone, and then the last one at the small narrow segment. Okay, so that usually gives you the diagnosis. What's the other question? The anastomosis?
Yeah, let me go back to the question number 2. It says, I didn't understand how you explain the resection and anastomosis using a one-stage transanal pull-through.
Okay, yes, you try to see, I put some slides. Yes, once you get above the transition zone, you don't just resect an anastomose. Yes. No, you resect it piecemeal. Like I said, I usually start mine anteriorly. However, you can start at whichever side, but as you resect, you'll be anastomosing, and as you resect, you anastomose round. I know it's a bit difficult, especially for general surgeons. Of course, you can do, just like total transanal total mesonoid.
Yeah.
Yes. So I think that's the best I can do to explain. I don't know. Maybe the person can send me, or we can talk after the lecture or whatever. Not after the lecture, because I should be back to Nigeria very soon. This week. So
I have one more question here. Do you, in the 3-stage or the 2-stage procedure, do you resect the aganglionotic segment at the first stage? Because my concern is if you resect the aganglionotic segment at that stage, you'll be disturbing the pelvic peritoneum. So when you go back at your second stage to do your anastomosis, you will have a more difficult pelvis to deal with. So do you leave a segment of the sigmoid in there, or you leave a mucous fistula while you have a colostomy?
Yes, thank you very much. That one, we do it for adults or older children who have had this aganglionosis with a very big colon, that kind of thing. So what you do in the first stage, go in there and do sigmoid colectomy, but you bring the rectum out as a rectostomy, okay? And then the ganglionated segment, bring it out as a colostomy. Now, the aim of that is to make sure that the function is there. Of course, once the colostomy is working, you know that you have ganglion cells there, isn't it? And by the time the bowel caliber reduces, you now go and do either an open surgery or even the transanal put. You do it transanally, but you take down the colostomy. I don't know whether I was able to explain that properly.
Yeah, you did. So if you
so you don't do any pelvic dissection at all.
Dissection. Thank you. That's all I wanted to clarify.
Yes. Yeah. Thank you.
Yeah. Do we have other questions before? I know how we're doing with time, Mr. President. I know they have a lot.
Yes, we are already eating into the time of the business meeting.
So I think we don't have any other questions now, but I want to thank Professor Chirdan for this very exciting, very informative lecture. And I think we've all learned a lot from it. And it's and this, I think, has brought a lot of pediatric surgeons into our fold this evening. So thank you very much. And we look forward to more exciting and interactive meetings like this.
And thank you also for the many questions, because it means that everybody was with me, when the lecture was given. So thanks for all the questions.
Thank you.
Thank you. Thank you very much, sir.